Good afternoon to this Nobel Inspired Lecture that is hosted to coincide with a period during which this year's Nobel laureates are being announced. I am Mia Malan and I'm the editor of the Bekesisa Center for Health Journalism, and I'll be facilitating this webinar. It's about a year after our previous Nobel Inspired Lecture about the meaning of science in the age of COVID. And as today's webinar, that lecture was co-hosted by the Embassy of Sweden in Tshwane and the National Research Foundation. And today we're also fortunate to have the same two renowned speakers as then. Professor Salim Karim from South Africa and Dr Anders Tegnell from Sweden are two of the world's top epidemiologists. I will introduce them as they speak, but I would like to thank both of them for making the time to share their insights and their expertise today. So a little bit about how our webinar will be structured. We will start off with short messages of the National Research Foundation and also the Swedish Embassy in Tshwane, and then we'll move on to the lectures of our speakers, which will be about 20 minutes per speaker, and they will speak about the challenges with science that was experienced in the past year, also how it was applied in their countries a little bit, and also how we used science to respond to the COVID challenge in general. And then that will be followed by a 20 to 30-minute question and answering session, during which you will also be able to pose your questions to the speakers. So please do enter your questions on your Zoom screen into either the Q&A or the chat box. And if you're planning to do live social media postings during this webinar, we have two hashtags that you can use. The one is Nobel Inspired again, and the second one is Nobel Prize. So we're now going to hear a quick message from Sweden's Deputy Ambassador in South Africa, Amy Larsson. Mrs. Larsson.
Thank you so much, and good afternoon to all our viewers today. And thank you all for joining us. So my name is Amy Larsson-Jane, and I'm the Deputy Head of Mission at the Swedish Embassy in South Africa. Let me start by thanking everybody involved in this year's first Nobel Inspired Lecture, including not least our collaborative partners from the National Research Foundation with CEO Dr. Fulofelo Nelbamondo, but also of course our two keynote speakers, Professor Salim Abdool Karim and Dr. Anders Tegnell. And of course also our eminent moderator, Mia Malan from the Bekesisa Center for Health Journalism. I'm very pleased to see that we've been able to follow up last year's interesting and very much appreciated and very much viewed lecture with Professor Abdool Karim and Dr. Tegnell. I believe we had 26,000 views of last year's lecture. I'm certain that a lot of insightful knowledge will be shared about the development of the pandemic, the lessons that have been learned over the past year, and how two renowned scientists view the future of the pandemic. The annual Nobel Inspired Lectures coincide with the announcements of the Nobel laureates. The Nobel Prizes are among the world's most prestigious awards, and from a Swedish perspective, we view them and the internationalism and excellence that they represent as part of our national identity. The joint Nobel Inspired Lectures showcase research excellence and emphasizes the importance of research, technology, and innovation in addressing the real challenges that confront communities. It also exemplifies the strong relations that exist between Sweden and South Africa. As much as the Nobel is a celebration of excellence of individuals and their beneficial impact on the globe, it's also an opportunity to inspire the next generation of scientists and creative innovators in South Africa and Sweden in the spirit of Alfred Nobel. Today's lecture is a great opportunity to interact with two of our country's most prominent leading figures in the field of epidemiology. I therefore encourage all our viewers to put questions to them using the chat functions during the conversation. I would also like to invite everyone who's attending today to also join us on Thursday for the second Nobel Inspired Lecture this year. It will also be at 2:00, and we'll have two top climate researchers from South Africa and Sweden delve into the much relevant topics around climate change. I want to conclude by saying that we are pleased to see the continuation of the strong relationship that we have with our collaborative partner, the National Research Foundation. We look forward to co-hosting many more discussions on science and its importance for the development of fair, sustainable, and healthy societies. And with that, I'd like to wish everyone a very warm welcome, and I look forward to an insightful dialogue about COVID-19 and the meaning of science during a pandemic. Back to you, Mia.
Thanks very much, Mrs. Larsen-Jane. We are also going to hear a message from the National Research Foundation, which is represented by their CEO, Dr. Fulufelu Nelwamondo.
Thank you very much. Deputy Ambassador Ami Larsen-Jane, Dr. Anders Tegnell, who is a state epidemiologist of Sweden, Professor Salim Abdool Karim, who is the director of the Center for the AIDS Program of Research in South Africa, CAPRISA, and the DSI NRF Center of Excellence in HIV Prevention, Ms. Mia Malan. Ladies and gentlemen, let me thank you all for joining us for this follow-up discussion on the meaning of science in the era of COVID-19. A special word of thanks goes to our distinguished guests and our panelists, Professor Abdool Karim and Dr. Tegnell, for accepting our invitation. The strong relationship that exists between Sweden and South Africa, and reflected in the enduring partnership between the NRF and the Swedish Embassy in South Africa, is one that is based on shared values. And particularly in this case, the shared recognition of the value of science and the scientific ethos. Today's topic speaks largely to a critical pillar of the NRF's mandate, which directs the organization to promote the ethos of science and society, and in addition to that, the engagement of society with science. We are therefore quite pleased to have such eminent scientists reflecting on the meaning of science in this era of COVID-19. Deputy Ambassador, please be assured of our continued support and the appreciation of the partnership between the Swedish Embassy and the National Research Foundation. As you just mentioned, we are looking forward to co-hosting a number of sessions of this nature in the future. Thank you very much.
Thanks very much, Dr. Nelwamondo. We're now going to move on to the lectures of our two speakers. And it is my great pleasure to introduce Professor Salim Abdool from South Africa. Professor Abdool Karim is a South African clinical infectious diseases epidemiologist with whom South Africans became very familiar over the past year and a half, first as the now former chair of the Ministerial Advisory Committee on COVID-19 and then later the co-chair. But Professor Abdool Karim is also a world-renowned HIV researcher and the director of the Center for the AIDS Program of Research in South Africa that we also know as CAPRISA. And he's also a professor at Columbia University and an adjunct professor at Harvard. Professor Abdool Karim, the floor is yours.
Thank you very much. It's indeed a great pleasure and an honor for me to deliver this year's Nobel Inspired Lecture after a thoroughly enjoyable one a year ago. I just want to check with you that you can see my slides.
You can see them clearly.
Okay, great. Wonderful. So I would like to share with you some thoughts on science and the meaning of science in the era of COVID-19 and to reflect on it 1 year later. And as I listen to Deputy Ambassador Larsen-Jane and to our NRF CEO, I hear from them that this is a pandemic that has caused mayhem in many people's lives. It has upset economies, it has upset the social order, it has upset what people were trying to achieve and how we have been trying to go about our lives. So how has science and how has our understanding of this pandemic changed in the course of this last year? What I want to do very briefly is I'm going to talk to you about, just very briefly, about the pandemic progression in the last year. Our lecture in 2020 was on the 8th of October. So everything I want to talk about are things that have happened since the 8th of October. So think about it, you've been a Rip Van Winkle. You fell asleep on the 8th of October last year, you woke up, and I'm going to give you a very quick summary in 20 minutes about what has happened in that time. So I'm going to talk about the three most important technological developments. I'm going to talk about the three critically important mistakes that have been made in the response. And I'm going to talk about the three most underestimated challenges that we have in the COVID-19 pandemic. So let's plunge into it. We are now almost 2 years into the pandemic. And when we look at the way in which the epidemic has grown, we are closing in on 250 million cases, and we are at about 5 million deaths. And if you look at the way in which the pandemic has progressed in the world, we go through a succession of waves, and each of these waves is driven by variants. And you can see across the board that the pandemic has spared no country. But this is more than a viral infection. I'll touch on just 5 of the major global impacts that SARS-CoV-2 has had. The first is that it has markedly increased poverty. A recent World Bank report pointed to the fact that there are as many as an extra 150 million people who are now poor. Hunger has increased markedly. A World Food Programme report shows that at least 161 million more people are now food insecure and go hungry each day. And this pandemic has created yet other epidemics, one of which is the infodemic, where we have been seeing an explosion of new information. And of course, we deal with the political instability and the protests and the fractiousness it has created in our society. That this kind of polarization in our society, not only being driven by social media like Facebook deliberately, but also by virtue of our differences and our different understanding about the way in which each of the public health measures play themselves out in relation to the way in which we treasure our individual rights. And finally, one of the things that has been quite disturbing is the way in which the pandemic has shone a very sharp light on the disparities within our societies. Disparities by race, by gender, just disparities in data access and vaccine access. And all of those disparities are now coming to the fore and being much more clearly demonstrated by this pandemic. So let's look at 3 important, new technological developments. I'm going to talk about vaccines first. Amazingly, when you think about it, at our last lecture, we didn't have any successful vaccines at that time. Well, it didn't take very long from our lecture on the 8th of October last year. Barely a month later, on the 9th of November, a company called Pfizer, a partner called BioNTech, published their first results showing that their mRNA vaccine was more than 90% effective. This is a clinical trial that involved the US, Turkey, Germany, South Africa, Brazil, Argentina. So it was a global effort that came together to show that this vaccine was effective in preventing SARS-CoV-2 infection. And now, of course, we have a whole panoply of vaccines that have become available and now are widely being used across the world. Indeed, many have argued that the development of vaccines in this kind of time frame was nothing short of miraculous and reflects the ability of science to do the most amazing things. But it's also in other innovations, in the innovations of diagnostics, for example, and now rapid tests are widely available. You can take them home, you can buy them. When you think back to when we had the previous lecture, we were using laboratory-based PCR, and the first rapid tests were becoming available for antibodies. So you can see how scientific innovations are assisting us in dealing with this pandemic. From now, no longer requiring complex laboratory tests, we can have a simple take-home test. And indeed, these tests are widely being used to ensure that businesses and schools can remain open and reduce the risk of transmission. But it's also in the field of scientific innovations that we've seen new developments in therapeutics. When we met a year ago, we had just seen the results of the recovery trial that showed that dexamethasone was effective in reducing mortality by about 30%. Since then, we've seen several new important discoveries that have shown effectiveness in preventing severe disease and death, whether it's in the combination antibodies that have shown to reduce mortality, or tocilizumab, an IL-6 inhibitor, or most recently, molnupiravir, an oral formulation marketed by Merck, which has shown to reduce death as well. Those results are not yet published, and all we have at this stage is the Merck press release to go by, which suggests that this drug is effective in preventing both death and severe disease. But just as importantly, it's not just that what we've shown works, we've also shown that many things don't work. For example, azithromycin was shown to provide no benefits, hydroxychloroquine, favipiravir, ivermectin, convalescent plasma, and lopinavir, ritonavir, commonly known as Kaletra. So we've also shown, and through research and through multiple studies, that these are treatments that have no benefits. And that's important. It's just as important to eliminate false hope and false treatments as it is to show that we have new and efficacious treatments. So let me go now to the three critically important mistakes that have been made in the COVID-19 response. And here I'm basically talking globally about what we have done. So let's start with perhaps one of the early challenges that we grappled with across all our countries, and that was the false promise of herd immunity for COVID-19. And there were proposals such as the Great Barrington Declaration that proposed letting the virus spread to get herd immunity with just focused protection of the vulnerable as a better alternative to a lockdown. Remember, this was in the pre-vaccine era. Of course, we now know with hindsight and with understanding the epidemiology of this virus that actually this was simply an ill-advised approach. Because even if you get large numbers of people infected, it's still too low for herd immunity because the new variants have a much higher R0, which means that the level of coverage, the level of immunity required for herd immunity rises quite substantially. And even if you're getting 70% of your population infected, the number of deaths you have to deal with are very substantial. And of course, many of our elderly live with others or have carers who are younger and who get infected and expose our elderly. And of course, many of the people we're dealing with are not only about dying, it's also about mild infections causing long COVID. So allowing the virus to run rampant was certainly not a good solution, especially since natural antibodies wane quickly and there's high levels of reinfections, particularly as new variants develop, because new variants often have the ability to break through immunity from past infection. So we now have a very clear understanding that this was an ill-advised approach and one of the errors that we made early on in this pandemic. But we made many others as well. And one of those was that when we looked at this virus for the first 7-8 months, we were quite struck at how this virus hardly changed. And we knew that the virus has a proofreading step in the way in which it copies its genetic code. And we knew that there had been one important switch from the ancestral strain, that's the original virus from Wuhan, that there was a D614G mutation that was spreading widely in Europe and in fact came to dominate the world. And once that variant took root, it remained dominant for a very long time. So much so that we began to wonder, is this virus really going to lead to major mutations? Well, that level of complacency was quickly changed when on the 14th of December, the UK announced the Alpha variant, and we here in South Africa on the 18th of December announced our discovery of the Beta variant. And shortly thereafter in January, our colleagues in Brazil reported the Gamma variant, and in March of this year, our colleagues in India reported the Delta variant. Initially, they reported it as a double mutant. And we now know that each of these variants of concern have major changes that lead to, in some ways, greater transmissibility, altered disease severity, and differences in immune response. And now we wait to see what's next. What's the next variant after Delta? Because that remains for us a major challenge. And the variants have had a major impact. If you look here, I'm presenting the first waves in India, Brazil, and South Africa. India had a relatively mild first wave. In fact, they were already describing how they had conquered this virus, that it wasn't really a problem in India. In Brazil, they were dealing with quite a severe first wave. And in South Africa, we had pretty bad first wave. But when you look at the variants and how each of the variants led to a second wave, and in the case of South Africa, both a second wave and a third wave from two different variants, we're getting some idea of the impact of genetic variants in this pandemic. And of course, we understand now that the variants indeed have changed the COVID-19 endgame. Gone was this idea that we had in November last year. Oh, we have a vaccine. We have a vaccine. All we need to do is give everybody the vaccine and we'll solve this problem. Well, we've learned that actually it's not that simple. That the variants of the virus are putting pressure on us and putting pressure on the vaccine immunity. And we're seeing how, as we go along with time, we're seeing different variants emerge, and they are increasingly causing infections and breakthrough infections. So we have to rethink what that end game is, and we have to reconfigure our thoughts about how to look at the future of this pandemic. And then the third point I want to talk about, which for me is really one of the worst of the errors that we have made, and that is we have promoted self-interest in this pandemic. And in focusing on our self-interest, we have led to a situation of gross vaccine inequity. And then that inequity is fed by vaccine nationalism and hoarding of vaccines by several wealthy countries. And so you leads to this kind of situation where the situation in Africa is that less than 5% of the population of this continent have been vaccinated, compared to about 50% globally have been vaccinated. This kind of disparity speaks volumes of the challenge that we face in ensuring that poor countries receive vaccines and are able to get those vaccines into jabs in arms. And this is all in the presence of a situation where COVID vaccines that were actually being filled and finished here in South Africa were being exported to Europe and not being distributed right here in Africa. South Africa had bought something like about 30 odd million doses of the Johnson & Johnson vaccine, and the J&J vaccine was being filled right here in South Africa. But instead of the doses coming to South Africa, we received none of that 30 million we bought, while the doses that were being manufactured, or at least being filled here, were going to Europe. So it's just reflecting the real problems we grapple with in dealing with vaccine nationalism and self-interest. So let's look at now the three most underestimated challenges in COVID-19. The first of which is the growing clinical problems that we see in long COVID. It's a condition we didn't even understand when we had our meeting a year ago. Now we have a better understanding that it affects somewhere between 10 and 30% of infected people. And it's really about chronic symptoms that don't go away. What we used to originally call long haulers is now just called long COVID, where symptoms persist. And one of the most important symptoms is that of brain fog, where people aren't able to concentrate, they can't work, they can't read, and they have, shortness of breath, they have difficulty in getting on with their daily routines. We don't fully understand what's causing it. Some have suggested it's microemboli, some have suggested it's autoimmunity. We just simply don't understand. But what we do understand is that long COVID is as common in people who've had asymptomatic or mildly symptomatic infections as it is in individuals who've had severe infections. So this is a growing problem and a growing issue that we will have to grapple with in this pandemic. The second thing I felt we have underestimated very substantially is how the medical fraternity has become complicit in anti-vaccine and misinformation and promoting unproven COVID-19 treatments. I mean, in South Africa, we heard how one of South Africa's, the first female heart surgeon in South Africa was promoting anti-vax comments in a Zoom webinar. We've seen how doctors have been promoting ivermectin on television and in all different forms of social media as well. And it's not unique to South Africa, of course, it's everywhere, and including in the US, for example, where this doctor that you see in the picture on the bottom left-hand side, outside the White House or outside some important government facility, was promoting hydroxychloroquine. And we've seen how people like Dr. Pierre Corey, in a Senate hearing, just spouts what is obviously incorrect information about the efficacy of ivermectin. So we've seen how the medical fraternity has, in not all of it, but in small but important members of this fraternity, have become important drivers of anti-vaccine information and promoting unproven treatments. In fact, it strikes me how many of those who are anti-vaccine are pro unproven treatments. It's quite amazing when you think about the conflict or the contradiction that poses. And then the third is, for me, the thing we've underestimated. There's the challenge in implementing an equitable vaccine distribution system. That on the one hand, we are seeing a glut of vaccines, so much so that there are millions of doses of vaccines that are expiring in the US and Canada. And in many of these countries, they're hoarding vaccines because they're not sure about whether they're going to be giving third doses. They're not sure about whether they're going to be vaccinating children, so they just hoard the doses. When those doses are desperately needed by COVAX to distribute to poor countries. In fact, COVAX is going to miss its deadline for this year, its delivery targets, quite substantially, by hundreds of millions. And Africa is facing currently just its 2021 shortfall of 470 million COVID-19 vaccines. So this, for me, is something that we completely underestimated. We underestimated how wealthy countries were going to behave in a way that would deliberately ensure that poor countries didn't get vaccine doses. So just how broken is the vaccine distribution system? Well, put very simply, in the way in which we distribute vaccines in the world, individual drug companies decide who they're going to sell to, when they're going to sell, what price they're going to sell to it, with most of the vaccines actually being funded in their development by the public purse. So instead of being a public good at a global level, COVID-19 vaccines are a commodity to buy and sell, and occasionally are being used for political benefits, where country X donates to country Y for some political gain. And all of this has furthered and created greater inequity in vaccines. In my view, nothing short of vaccine apartheid. And we know that the UN declared apartheid a crime against humanity. We need, put very simply, to implement the WHO's global vaccine strategy. It has a clear plan. I was part of the committee that put this together. This gives us a road forward. And part of this road forward is about trying to achieve equity. There is no scenario where one country will vaccinate 90% of its population and think that it's safe, while the vaccine is spreading rampantly in poor countries in Africa. So let me conclude that we need to do better in pandemics. The pandemic needed global cooperation. COVID-19 begged for global cooperation. Instead, countries chose a me first and self-interest. I guess somewhat justifiably, not knowing what to deal with. But little was done to protect the poorest or to distribute vaccines equitably. Global tensions, such as that between the US and China, were heightened. Wars and conflicts raged on despite UN pleas for ceasefires, which went unheeded. The WHO, our world's lead agency to fight a pandemic, became a political battleground between the US and China. In this pandemic, humanity needed to create a united front against a global threat, and we failed. In my view, we cannot afford to fail again. We must succeed as we deal with the rest of this pandemic, and we must succeed because there are going to be future pandemics. And so we have to succeed in the next pandemics for the sake of humanity. Thank you.
Thank you so much, Professor Abdool Karim, for your great insights on the technological developments, the mistakes, and the COVID challenges we faced over the past year. Thanks for sharing those. Just a quick reminder to all of you that if you have questions for Professor Abdool Karim or Dr. Tegnell, you can enter them on the Zoom screen in the Q&A boxes or in the chat function. And if you're live tweeting, our hashtags are Nobel Inspired and Nobel Prize. We're now going to move on to Dr. Anders Tegnell's lecture. He's been Sweden's state epidemiologist since 2013. Dr. Tegnell is also the head of the Department of Public Health Analysis and Data Management and a Deputy Director General at Sweden's Public Health Agency. He's also done work in the Democratic Republic of the Congo during the country's Ebola outbreak in 1995. Dr. Tegnell?
See, now you can hear me, I hope.
Yes, we can hear you clearly.
Yes, let me start by saying that I unfortunately completely agree with the, see if I can get up my, presentation up online. Can you see my presentation now?
Yes, we can see it.
Like that instead. Okay, let me start by saying that unfortunately I completely agree with Professor Karim's final remarks. There would have been so much more we could have done on a global level to ease the pain of so many during this pandemic. The vaccines is an excellent example, but you can also think about all the travel bans and different travel restrictions we put on everybody, that we exported different kind of measures all over the world without thinking about how important the context is for the measures to work in a proper way. So there's many, many things we need to do much better during next pandemic. I can completely agree with that. And I was also sure that Professor Karim would give you an excellent background on the COVID-19 problem from a medical perspective and from a global perspective. So I'm going to do it more on a Swedish perspective and thereby making some comments and connections to what Professor Karim already talked about from a country perspective. And I hope that can add to the discussion later on. So I think I showed this one last time too, but let me just remind you about this, because I think this is very much connected to one of the important things that Professor Karim raised, and that's the problem with health equity. The problem, this pandemic has definitely increased health equity on a global level, but also on a national level, even in rich countries like Sweden, because this has really hurt our minorities, our immigrant groups, and so on, much more than the population at large. And we can, from the very beginning, and unfortunately all through the pandemic, those are the ones that have dominated our intensive care units. Unfortunately, also those that have been most difficult to reach with vaccinations. So generally, they've been hurt a lot more than the population at large. And I think that's why it's been so important for us as a public health agency all through this pandemic to look on this, the measures we put in place, not only from a control of disease perspective, but also from a public health perspective in a broad sense, and not least on it as from the health equity perspective, because we know that's going to be important in the long run. And to minimize the negative effects of the pandemic, we need to not only stop the spread of the disease, but also minimize the hurt we can do by many of the interventions we have put in place. So the agency's background in mental health, in non-communicable diseases, in substance abuse, in sexual reproductive health, and so on, has really helped us to keep a bit broader perspective on how you can deal with a pandemic, which this pandemic has really shown the need for. So what has happened in Sweden? Just a quick reminder, and also because it's, I think one of the aspects of this pandemic, it's played out so differently in different countries. Professor Karim showed us some examples. This is from Sweden. It started out here back in early 2020 with this rapid introduction, because Swedes travel very much during the spring and winter holidays. And we had a huge first wave, which really hurt the country enormously. You can see it even better here at the ICU. We have never had as many ICU cases as during the spring 1.5 years ago. Interestingly enough, the change of variants have not really been very coordinated with our different waves. I think it's been most clear here because the Delta variant was introduced in Sweden in the spring of, or late winter spring of 2021. And that was during a period where we had a decrease in the amount of cases, and the decrease continued. This was, of course, a combination of vaccine effects and seasonal effects. I don't know what you've seen in South Africa, but in Sweden, the seasonal effects of this virus has been quite dramatic. And during both our summers, which you can see more clearly here in the ICU, we have had a very low spread with and without the vaccine. What you can see is the difference is that the Delta vaccine took off earlier. So obviously it's different than our previous Alpha vaccine because the seasonal change is just needed to start before it starts spreading. But fortunately, the vaccine program stopped the spread at a reasonably low level. But I think many countries, or several countries in Europe, had the same development, that in spite of the introduction of the Delta variants, that did not really, at least not during the first part of it, affect the spread, the epidemiology all that much. But I think now in the fall we can see it more clearly because many countries who were not so dramatically hit during the previous waves had very bad outbreaks now during the fall, especially the ones in Europe that did not vaccinate so much. The death toll has been enormous. I think we, on a global level, has underestimated this very, very much. I think the global death toll is most likely very, very much bigger than we think. We have in Sweden compared to excess death, that is how many more deaths have we had in Sweden than compared to the last 5-year period. in the same seasons and so on. And there is an excess death, but not as dramatic as the number of deaths that we see in our statistics. And I know from other countries that there is an enormous underreporting of the number of deaths, especially in the elderly, where most of the death toll has taken place. Once again, we can see the dramatic effect of the vaccines here in the end. In spite of us having a new spread of the virus, the death toll remains low. Once again, a signal that the vaccines has really been one of the major scientific breakthroughs during this pandemic. Without the vaccines, we would have kept on having enormous problems also in the rich world. Because vaccines has really become the sort of savior in Sweden in many ways. We can see there's about 10 million inhabitants in Sweden total, which makes it relatively easy to transfer these figures into percentage of the population. We're also, up until this stage, only vaccinated down to the age of 16. So our coverage is very high, and we're getting more and more people also to take 2 doses. We have been spared the phenomena that we talked about earlier with vaccine hesitancy. Even it's rampant in social media in Sweden also. It does not really affect the people's willingness to get vaccinated. We have named a number of surveys, and the people who have said actually no to be vaccinated are around 5 to 10%, not more than that. And we can see that most of the people who have been hesitant has also been, in the end, going to be vaccinated. When it comes to our migrant populations, which has been behind on that, they are catching up, but it takes longer time to reach them. You need to work a lot more. You need to make vaccines available in manners that we are not used to in other areas. But slowly but surely, we're also increasing the coverage in those groups. And when we ask people in those groups, the hesitancy is also actually very low. So hopefully, the global phenomena will not spread to Sweden to the same extent it's been rampant in many other countries. I think the background to this is a high level of trust between the population and the government, the agencies, and not least the healthcare services. And that's been so very important for our childhood vaccination program, where we usually reach around 98% of all children born in Sweden, irrespective of the parents' background. So I think that was the basis for the high level of trust in vaccines in Sweden. We can see here we also, like in many public health interventions, we do best with the elderly, and where we reach more than 90% of the most vulnerable groups. And this is most likely the background to our death toll being so low. When it comes to younger people, it's more difficult to get them on board. The 16 to 17 here is not really correct, because that's a group we've started vaccinating quite recently, so they are still moving upwards quite quickly. So we believe we can reach higher levels also in those groups. But we are fighting with this last 10, 20% in some of the age groups here to reach them, because as Professor Karim pointed out, to get anywhere in this pandemic, you need very high levels of vaccination coverage. And there is, I would agree, there is probably no way we're ever going to reach a full herd immunity that will stop the transmission of the disease. And that's also partly, we need to remember that the problem with these vaccines, they are excellent vaccines when it comes to protecting people from sickness and death, but they are not that good in stopping the transmission, which means that even vaccinated people to a certain extent also transmit the disease. And that's why I believe we're going to have a continued transmission of this disease for the foreseeable future, if probably also forever. But hopefully we're going to get vaccines in the future that are better at stopping also the transmission, and that will make everything much easier, I think. But right now we can protect our population from hospital care, we can protect them from death, but not so much from mild disease and from the transmission of the disease. Then we need to reach a very high level of vaccination coverage, which is probably not very realistic to believe that we can do. So what we've tried to do, we have really tried to minimize mortality and morbidity in the entire population and to flatten the curve. This has, in some instances, been understood that we try to achieve herd immunity. That is not the case. We have, I think, early on understood that herd immunity, we can never really reach that with this kind of disease by natural infection. It has never happened with flu and other diseases, or most likely never happened with COVID-19 either. You might be able to reach it with a very, very good vaccine, but probably not with the vaccines we have in place today. On the other hand, the immunity of the population will, to a certain extent, of course, help in that it would slow down the spread of the disease, and together with certain measures in place, it can make it possible for us to keep it under control. We have, of course, worked with protecting risk groups. It's very, very difficult, but still needs to be done. I think to a certain extent it's been possible, but not completely. We have not followed the lead of some countries and closed down the country completely. Instead, we have closed down the areas and the environments where we know that we have a high level of transmission, and that has proven very effective, and to the extent that we believe that it's almost as effective as closing down the country as a whole, but very much less harmful to the population. And it will be sustainable over time, which lockdowns over and over again has proven not to be, because they are really a major problem for the population. Sorry. So what we have worked with is a combination of binding regulations and voluntary measures, and this has made it possible for us to stop transmission in areas with a lot of transmission, but still keep the society open to a certain extent in areas where we see a very low level of transmission. This has been backed up by a massive communication campaign, and that has been made possible to reach the population. As of course, we're also going back to the trust between the agencies and the population. So where are we now? 1 year later, there's been a lot of discussion about the effects and of the measures we have had in place in Sweden compared to other countries. I think the differences have been vastly over-exaggerated. The differences are not that big. As I said, it's mainly around that we, instead of closing restaurants completely, we give the restaurants rules that they can keep on running in a safe environment, and that, at least in the Swedish context, has worked reasonably well. And if you look at the graph, which shows the development of the pandemic during the last year and a bit more in a number of European countries, many of them with strict lockdowns, some of them like the Scandinavian countries with less strict lockdowns and sometimes no complete lockdowns at all. The Swedish curve, which is the lilac curve, is not that different from some kind of average between different countries. If anything, our curve seems to be less dramatic up and down than we've seen in many other countries. But this is very complicated, and the scientific evaluations we're going to make in the future are going to have, I think, quite a challenge to differ out what is the cause and what is the effect of a number of the things we've done, since so many of these are so context driven. And obviously, trying to use the same kind of measures in different countries will produce very different results. So when we look back, our healthcare sector has been stretched, but managed to transform itself and increase the number of ICU beds and basically provide a reasonable quality of care to everybody, both with COVID-19 and with other diseases. But there is a number of things we need to improve. Stock supplies, testing capacity was very low in the beginning. The medical community has, as Professor Karim pointed out, learned a lot during this. I mean, the survival rate in our ICUs is vastly different now from what it was in the beginning. That is partly due to new medicines, but I think also very much due to that we now know much better how to take care of these people in the ICU setting in an effective way, to keep them there for as short as possible, but also to get them out in as a good condition as possible. But our socioeconomic inequality has been extremely well exposed during this time. So this I think is what our science will have to deal with in the next years when we look back at this pandemic, is how do you balance during a pandemic, the interventions you wouldn't have in place to stop the transmission, with the effects of those interventions on public health as a whole. So how can we stop the pandemics early on? How can we find them early on? I think for a few weeks very early on this time, at least we hoped that we could stop this in China, but it was quite soon after that very evident that it was not possible to stop in China or stop anywhere. I hear now that even New Zealand has in the end seen that this is not a disease that any borders will stop in the long run. We need to collect, and I think that's one of academia's big things to do now, better evidence for a number of protective measures and see how they actually work, in what context they can work, not least. And I think each country need to understand what level of enforcements do they need to have in place to have these protective measures in place. Media has played an interesting role in this. People are interested in science a lot more than before, which I think is positive. They're also interested in data in a different manner than ever before. We have a new word in Swedish, which is called hobby epidemiologist. So today, basically everybody in Sweden is an epidemiologist and can sit and look at the data. And I think there's a lot of data, but the problem is to understand how they can be interpreted and how they cannot. And there is other public health issues. Mental health is now coming up more and more clearly as one of the major things we inherit from this pandemic, together with, of course, the long-term COVID, but also the mental health in general. Domestic violence is on the rate, etc., etc. There is also healthcare debt in many countries that we need to work with. Cancers, a lot of other things that have not been treated optimally during this time. There's been a lot of economic impact in all countries, more or less, of course. And the human rights discussion will be ongoing, I think, when it comes to this pandemic. So we have had so many data during this time, and the number of confirmed cases, deaths, treated in ICU, vaccine coverage has been followed on national registers in Sweden, but also followed on a global level. And I think we have learned a lot on how to handle big amounts of data and how to use them, sometimes also misuse them, because they are not always easy to understand. We need to, as I said before, follow the negative health consequences for individuals, both directly, like with long-term COVID, but also indirectly from a number of the measures we put in place. And all these evaluations is of course already ongoing, but will need to continue. And I think that's one of the areas where academia and the public health agencies need to work together a lot to really harvest all the information and harvest all the knowledge we can get out of this, so we are better prepared next time. I think Professor Karim already pointed out some of the big things that happened. The vaccine, I know I was asked early on when we get the vaccine, I said if you're very, very lucky, maybe in 2-3 years time. A year later, we had not only a vaccine, we had also a very good vaccine in place, and then provided with a completely new technology when it comes to mass production. So I think this would mean a lot for vaccine development in many other areas, because we have a number of new production platforms and ways of delivering vaccines that the development is something we can use in many different areas. Diagnostics, of course, took a big step forward. Treatments also, even if treatments maybe not as fast as we hoped in the beginning. We learned a lot of different kind of data sources, at least in countries with a lot of data floating around. Everything from Google search data to how many people pass into subway cars every day in different parts of Stockholm and so on. Digital contact tracing was discussed a lot in the beginning. Never really took off, at least not in the European setting. Was maybe one of the areas we really thought that here we have one of the keys, but it never really took off in a way that was thought in the beginning. But it's, as I said repeatedly, it is complex. It's a very complicated pandemic, many parameters to take into account because of our countries are so different and have different contexts. So agencies need to work more with academia. Academia also needs to work a lot more together with the public health agencies, I think, to be better prepared for the next time this happens. And the public health agency do have a very close relation to Karolinska Institute. Of course, we have a lot of our people are trained in research and PhD students. And we also use academia to do a number of the surveys and investigations that we need to do. And we are now a source for a huge amount of data that can be used by academia during the next few years when we will look into and trying to understand this pandemic a bit better. So just a final few words. The containment and lockdowns in Sweden were not as visible in many other countries, but in many ways had the same impact, both when it comes to the breaking of transmission, but also on the impact on people's lives. Life has not been easy in Sweden either, and we can see that in the increase of mental health disorders in Sweden. We worked with voluntary measures, which is possible in the Swedish context, where you have a high level of trust in authorities and people will actually follow their advice to a high extent. And when it comes to the outcome, the pandemic in Sweden differs radically from Norway and Finland. I'm the first to admit that. But when we look to the EU and Europe as a whole, Sweden is not standing out in any noticeable way, I would say. So once again, a complicated pandemic will need a complicated evaluation. We need to look more on the other public health consequences on the pandemic, both direct ones, but also indirect ones by the measures we put in place. We need to follow up what this stress test did to our societies. Where do we see our weaknesses? And once again, health inequalities has increased on a global level, on a national level and all over. And we need really to think about how we can diminish those effects in the future. So we need to build back better and fairer, not least in Sweden, but also on a global level. Thanks very much.
Thanks very much, Dr. Tegnell. Thanks for sharing how Sweden dealt with the pandemic and also the results and the complexities around that. We are now going to move on to our question and answer session, and we're going to take some of your questions. Before that, I'm going to ask each participant one question and then we'll take your questions. And I'm going to start off with Professor Abdool Karim. I would like to know, Professor Abdool Karim, you've spoken about the mistakes the world has made in its COVID response, but if you apply that to South Africa, what mistakes have we made?
The sound.
Thank you very much, Mia. I'd like to just start by acknowledging Dr. Tegnell's presentation. He captured many of the key issues we are all grappling with. So when I think about South Africa, I think in many ways, among the things that we could have done differently would be quite a long list. But among them, I think we as a country should have taken a stronger position in trying to make a vaccine. And I've stated that publicly previously, that we should have done that, because we have previously made vaccines and we have a significant technology to be able to do that. But I think all in all, we did play a really important role in vaccine development. There were 4 vaccine trials, COVID-19 vaccine trials undertaken in our country. And of course, the J&J vaccine, we were the largest site and contributed the largest number to that vaccine trial. So there are many pluses that apply. I think the thing that is really taking its toll on our country at the moment is the very strong anti-vaccine sentiment and the way in which misinformation is, being spread in various different fora. And I think those are very difficult to counter because it's a small group of people who are being amplified by others. And I think that we as a country, just need to deal with professionals in a way that ensures that professionals do not, distribute information that is not shown to be accurate. And then finally, I think we need to be scaling up vaccine coverage at a faster rate. And there, we went through our first two groups quickly. That's the innovators and the early adopters. And now we're in the early majority where, they will get vaccinated when it's convenient. They're not rushing out there. They're not going to stand in queues. They don't mind getting vaccinated. They will get vaccinated. But we've got to find a way to reach those individuals. And that means that our vaccine approach has to continually change, because you're trying to reach different groups that have different motivations as you progress. And I think that the way the president announced the whole VUMA campaign is, I think, something that is on the right track, that we've got to get our vaccines out there to the individuals in order to get coverage, because we need to be aiming to get significant vaccine coverage, especially of our elderly, and in the region of 70–80%, in those who are above 65, so that it'll minimize the impact on the hospitals as we deal with future waves.
Thank you very much, Professor. Dr. Tegnell, I have a difficult question for you because it was such big news in South Africa today. So the vaccine inequity that both you and Professor Abdool Karim spoke about today was really big news in Tshwane, where your embassy is based. We had Doctors Without Borders protesting against European countries that they feel are blocking the TRIPS waiver, and that included Sweden. And one of the other issues is that we don't have enough vaccines for even first doses in Africa, but that many European countries are either already administering booster doses or are considering it. So in that context, what will Sweden do to address this inequity?
Yeah, that's a big question that I don't really feel for me alone to give any answers to, but let me at least put it like this. Yes, Europe have been hoarding vaccines, not so much maybe in a real hoarding yet, but more of a virtual hoarding. And I think what we are fighting now in Sweden very much is to avoid that these vaccines come to Sweden, because we have been signing contracts for far more vaccines than we need, and that we need to find solutions to getting those vaccines out to countries like South Africa and other countries who can use them much better. And that process is very much ongoing. We have already sent out quite a few million doses into the COVAX program, but there's definitely going to be a lot more to come, because as you've seen from our figures, we don't really see that we're going to vaccinate all that many more people in Sweden, at least not during the next few months. We have also been really holding back on extra doses. So far, we only give extra doses to the people who are severely immune compromised, who really need a protection, and to a few people above the age of 80. But yeah, I mean, I cannot more than agree that this inequity needs to be addressed on a global level, and not one country can really resolve it. And especially now, we need to do it quickly, because a number of countries have reached the saturation level of the number of vaccines they can use. Sometimes because they have a lot of vaccine hesitancy. Sometimes, like Sweden, we have really reached as many people as you can possibly reach. And then we need to be much faster and much better at redirecting the production that is quite big right now to other countries. So I saw on the Johns Hopkins site that the number of vaccinations given each day is actually falling right now, which is, of course, a little bit difficult to understand. But I think the background to this is that Europe and America is more or less saturated, and we have not really managed to redirect the production to the countries where there is still a lot of people who want to get vaccinated.
Thanks very much, Dr. Tegnell. I'm going to stay with you. There's a question from one participant who's asking, what is the pattern of mutations so far tell us about future mutations. Do viruses stabilize with time, or can we expect radical changes to the virus also going forward?
Yeah, I think this is a very, very difficult question to completely give a good answer to. If I ask the experts in Sweden on coronaviruses, they say that they are relatively stable viruses. And we also need to realize what we are doing right now is that we are able to follow the evolution of a virus on a level, on a time scale that we've never been able to do before. We actually don't know if this has ever happened before, because this is the first time we have the tools to actually examine viruses on this level. So we did actually see these changes, and possibly similar changes probably could have occurred during the Spanish flu, for example. We don't know today, but most likely something like that happened. I think I would say that radical changes, no, that happens very seldom. Viruses can give more severe disease, maybe slightly spread a bit better and so on. But the radical change so that they go from spreading in a completely new manner or giving a completely different kind of disease, no, that's very unusual. I mean, we can look at HIV, which I think is good. It's also a rapidly changing virus, but basically the disease has stayed to a great extent the same. I think the other good thing that we know is that the vaccines keep being reasonably good for all variants we have seen so far, which probably means that we have actually used a good part of the virus for our vaccines. But what will happen in the future, we don't know. Now we have had, there was a period when a lot of variants turned up. The Delta variant seems to be unusually fit, because even if new variants have turned up, they have never really been able to compete with the Delta variant. For how long that will last, I don't think anybody really knows.
Professor Abdool, Karim, did you want to add to that?
No, just to say that when we look at any virus, let's take measles as an example. We look at measles and it's very stable. I mean, you do get mutations, all viruses mutate, but the mutations don't fundamentally change much in the virus. And the argument is that measles at one stage was also going through multiple variants until it reached a point where it couldn't mutate without compromising its fitness. In other words, any new mutations it made that gave it an advantage came at a price. It had to pay some price for that. And so the virus reaches that sort of point at which it can't really change that much more. It'll just slowly evolve, but those are minor changes. So some argue that that point has been reached with the Delta variant. Others have argued that the virus still has more mutations or still more variants of concern that are going to emerge, particularly new variants that may have the ability to have some level of immune escape, because the current 4 variants of concern emerged in a period where there was widespread natural infection, but there wasn't high levels of vaccine immunity. Any new variant emerging at this time, in order to succeed, will have to have some level of escape from vaccine immunity. So that's the 2 scenarios. Have we reached a point where the virus is not going to change dramatically, or are we still going to see new variants? Because at some point it'll run out of new variants. So that's the big question, and nobody knows that answer. If I was a betting man, I would probably bet that this virus is not done with us. It's still got a few more variants up its sleeve. We're going to see a few changes occur, and mostly those changes are going to be driven and created in people who are severely immunocompromised, because you need persistent infection over many months in an individual to get a new variant. And so that's why the point that's being made is that immunocompromised people, you must protect them. Give them, because many of them don't respond to 2 doses, give them a 3rd dose, because they are so important to the future of our pandemic.
Thanks, Professor. On that subject, Vio wants to know when it comes to booster doses and how we distribute vaccines across the world to address the pandemic globally. What is the science? What does the science tell us about how we should distribute doses? Does it make sense scientifically for some countries to start with booster doses while others don't have enough vaccines for first doses? Scientifically, what would the answer be?
So let me start with one very important point, and that is that early on in the pandemic, the WHO, together with Gavi and with CEPI, created a mechanism to provide vaccines in an equitable manner. They called it COVAX. And the whole idea behind it is that vaccine manufacturers would dedicate their doses and that all countries would become part of COVAX, whether they bought their vaccines self-funded or whether they needed it donated. The problem was COVAX was undermined from the word go. It was undermined because the US refused to join and China refused to join. So the two most important countries where they have very significant manufacturing capabilities refused to be part of COVAX. Of course, the US relented when its president changed. And of course, China more recently has joined COVAX. But the damage was done. The damage was done that COVAX was essentially left to the market. And in a situation where countries that are making decisions to give out booster doses are able to secure doses from vaccine manufacturers almost immediately, while COVAX is continually being pushed to the back of the queue, so that COVAX is not getting doses it has already purchased. Because who's making the decisions about who gets vaccines? It's the companies manufacturing them. It's the companies who decide that, you're a favored country, you get your vaccine doses first. You're not a favored organization, you go to the back of the queue. We'll give you vaccines when we want to give you vaccines. So that's what we're really grappling with. We're grappling with a situation where the world is being held hostage to the whims and the driving forces that big pharmaceutical companies that have made these vaccines are driving. Now, that problem is being compounded by the current drive where many of the wealthy countries are now trying to introduce, or in the process of introducing, if they haven't already, booster doses. Now, booster doses are warranted in certain instances. The two instances where there are pretty strong evidence is immunocompromised individuals that I've already touched on. And the second is the elderly, because the elderly need additional doses to boost their cellular immune responses. That's why they get severe COVID. They don't have enough CTL activity from the first two doses. So say those, most of that research has looked at over 80s, but let's say, over 65. So there's a justification to give boosters to those two individuals about 6 months after their first two doses. But for the rest, the evidence is flimsy. The evidence that there is waning immunity against severe disease is almost non-existent, because all of the data suggest that, in fact, immunity against severe disease is not waning, or if it is, it's minor. And the strongest evidence for that comes from the Goldberg data from Israel, which shows that between January and March, individuals who were vaccinated in those 2 months, the difference in vaccine efficacy for severe disease is just 2 or 3 percentage points. So that's minor, and both are still in the region of 90% protection against severe disease. So severe disease, there is no evidence to support waning immunity. But there is evidence to support waning immunity as a whole for clinical infections. As antibodies go down, which they will in any vaccine scenario, we are seeing breakthrough infections occur much more. And that's compounded by new variants that have the ability to cause more breakthrough infections. But because countries such as Israel, as an example, that's giving booster doses to the entire population, including young people, they are consuming doses that should be saving lives in Africa. Instead, they're being used to prevent mild infections in Israel. So that inequity is what is compounding our current problem in the maldistribution of doses. And that's what led to the Director General of the WHO to call for a moratorium on giving booster doses until the end of this year, because we need to get at least healthcare workers and the elderly vaccinated in our poorest countries, because they are at such high risk of severe disease and death before we start giving booster doses in other parts of the world, with the exception of the two I've already mentioned, which is the elderly and immunocompromised individuals.
Thanks, Professor.
I can add to that. Not that I have any other opinion. What we are actually doing in Sweden is we are following breakthrough infections very carefully. We can do that because of our registration, so we don't have any problem with that. And we can do it in different age groups. We can do it for different diseases and so on. So we don't, at this stage, we see a small signal from people living in the elderly homes, the very specialized elderly homes in Sweden for the very sick, very elderly people in Sweden. There we start seeing a small rise, and they were vaccinated among the first now 7 or 8 months ago. So we're actually starting a program to vaccinate them. And that's the science. And the science, I would say, on a general level, says that it's always better to give a dose to somebody who's not vaccinated than to give a third dose to somebody who has received 2 doses before. And that's on a global, national, or regional, or whatever level you talk about. And that's what we're also telling all the regions in Sweden. The first priority is to get the people vaccinated who are not vaccinated at all. And I think that's also is transferable to the global level. You can never use the vaccine better.
Thank you, Dr. Tegnell. There's another question for you. It's about long COVID. Someone wants to know, how long is long COVID? Is it lifelong, or do you see that those who get it early on in the pandemic has now recovered from long COVID?
I think we need to realize, and I'm sure Professor Karim can help me on that because I'm not a clinician anymore, that long COVID is so far very heterogeneous, to a great extent, not very well understood disease, which was most likely, like many similar diseases that we see, would turn up to have a number of different backgrounds. And there's probably some kind of core in it, because as an infectious disease clinician, I know that long-term symptoms after infections are not unusual. That is something we know, we see in the infectious disease clinic fairly often. And any infection can basically sometimes produce it, and the symptoms are very variable, very personal, and so on. So I think at this stage to say for how long and whatever this will last is impossible. But I would say that the majority of the people get well. At least that's the experience in Sweden so far. But if there is a small remaining group that will remain with some symptoms, most likely, like it is with normal post-infectious symptoms. There is a few people around who never really completely recover from a number of infectious diseases. So that will most likely also happen with COVID. We sometimes don't remember the huge amount of cases we have for this disease. And that means that we see things that we normally don't see because the diseases are fairly rare, and then we don't see these outliers, so to speak, that the long-term COVID is.
Thank you. Professor Abdool Karim, did you want to add to that?
Just to say that, because we don't know this disease for the long term, the idea was that when you recovered, you recovered. So it was an acute infection. That's what we understood. Then we realized, actually, no, you don't all recover when you're in that acute phase. There is some long-term sequelae. Now, not most, but many viral infections have a chronic form. Even measles has SSPE, all these diseases. And the chronic form is often driven on the basis of an immune response, not the virus itself. The virus itself is cleared. It's that the body's overreaction to the virus leaves some long-term sequelae that are immune-based. Whether they are related to autoimmunity, we don't know yet, but it's thought that at least there's some immune basis to it. And in the issue of COVID-19, with time, we will be able to describe, the two clinical forms of COVID: the acute form, which we know, mostly is asymptomatic, mostly is mildly symptomatic and recovering, but a small proportion requiring oxygenation, and an even smaller proportion requiring ICU and who die. And then we'll describe the new form of the COVID, which is the chronic COVID. And the chronic COVID is about those who have the long-term sequelae of the infection. And I think long COVID is that we don't fully understand chronic COVID yet. So we're calling it long COVID until we fully grasp what's driving those symptoms, what's the underlying pathology, and then we'll be able to encapsulate what chronic COVID really looks like.
There's a question for both of you here. It says the seasonal aspect of the waves don't seem to match up in Sweden and South Africa. One of the worst waves in South Africa was over the South African summer in December, January last year. Why does the weather and season play a stronger role in Sweden and Europe than in South Africa?
Here we can guess. I think it's because the seasonal thing in Sweden, is not completely due to the weather, but very much more due to how we change our behavior in Sweden. I don't think I've only been in South Africa briefly a few times, but I don't think you change your behavior as drastically as Sweden does. In the wintertime, we're indoors all the time. We meet very closely with each other. We sit together very much in closed indoors environments, at home, at work, and all different instances. In the summer, we're outside as much as possible. And I think that those contact patterns in the different seasons are very, very different. And then, of course, the weather and the possibility for the virus to survive a longer time also plays a role. But I think that could be the reason why we see that the seasonal variations are so very strong in Northern Europe. We have the same seasonal variations for RS virus, for flu, for almost all respiratory diseases, and more or less pronounced that basically disappear in the summer. And I think it's not only South Africa. I mean, we can't really explain the huge waves going over India if you think that there is a strong seasonal component. So once again, I think this disease is unusually context dependent on the way the epidemiology develops.
Yeah, I'll just add to that one small point, and that is in South Africa, we now over the start, since we've had the first wave, we pretty much get our waves about once every 6 months. So we get 2 waves a year, one in the winter, one in the summer. And the gap between the waves has been amazingly consistent. Between 94 and 99 days, between the first and second wave, between the second and third wave. So we're seeing a pattern that's probably being driven to some extent by a wave leading to large numbers of individuals developing natural immunity. And now, as that immunity wanes, because natural immunity wanes, takes a dip very sharply within the first 2 to 3 months, that by month 4, it's quite low, and that's been described in many studies, that basically we don't have that protection. And in South Africa, it's been compounded with new variants that have been able to escape immunity that was generated by the previous variant. So for example, Delta variant caused infection in individuals who'd had natural beta infection previously. beta infection didn't protect you against Delta. So it protected you to some extent from severe disease, but didn't prevent you from getting mild clinical infection. So I think it's related to immunity, it's related to behavior, it's related to the fact in winter we all go indoors, especially in Johannesburg, Cape Town, much less so in Durban. So I think that's what we've been seeing, a mixture of all of those factors playing themselves out so that we get our waves, roughly in the middle of winter and the middle of summer.
On that subject, Professor Abdool Karim, there is someone who wants to know, what is your view on a fourth wave for South Africa? You've spoken a little bit about timing, the gaps between the waves, but how severe will it be?
Sure. So I was asked to do an analysis by Justice Moseneke for the elections, in which I presented him some possible scenarios. And so many have, when they've captured it in the media, summarized what I said and missed out all my caveats. So let me explain the caveats very quickly. So no one knows if we're going to get a fourth wave or not. Based on what we have seen, it's likely that we'll have a fourth wave. The fourth wave will largely be driven by a new variant, because our waves tend to be driven by new variants, because each of our waves leads to very substantial amounts of asymptomatic infections. So if we get a new variant, that's what's going to drive a significant fourth wave. If, however, we don't get a new variant, then we are likely to see a very small fourth wave. And that fourth wave will be blunted by the fact that we've already been doing quite well in reaching our elderly with the vaccine. So we've got about, I think, 70% coverage or so in those above 60. So that's what's going to blunt the impact of that fourth wave on our hospitals, as we've seen in the UK, as we are seeing in many other countries as well. So I anticipate we're likely to see a fourth wave. We're likely to see it in late December, and that it's all dependent on whether we have a new variant that will determine the shape and form of that fourth wave.
Thank you very much, Professor Abdool Karim. That was almost like a nice closing statement from you as to what South Africa has to face or might face in a couple of months. Dr. Tegnell, as a last question to you, perhaps also for a closing statement, there is a question about natural immunity. Someone says there is a perception that it's sometimes better to have natural immunity than the immunity you get from vaccines. So why is it that you still need to get vaccinated if you have had COVID? Why can't you just rely on that immunity?
Yeah, we don't know very much about the length of natural immunity yet. I can say that we've seen, actually in Sweden, we see very few breakthrough infections still, even after more than 1.5 years, which is interesting because I know that there are studies who see a lot more of them. We don't see very many, and I don't know why that is. Maybe there is also this kind of, you can also get a booster, a natural booster, when there's a lot of infection around. And there is also discussion how much does that impact on for how long you're immune. We don't know. There is so many things we don't know. In Sweden, we definitely recommend everybody to get vaccinated for a number of reasons. First of all, a vaccination after infection would definitely give you better and longer immunity than only having an infection. And also because we really want to get a good idea on what is the immunity of the population in Sweden. So I think, and that's what we do in basically all vaccination programs. We don't ask people if they've had measles before we vaccinate them. We vaccinate everybody. And that's the quick and the efficient and the good way to run a vaccination program. So I think we also come back to the traditions on how to run a vaccination program. There is no data so far on that there is any negative effects on getting vaccinated after you had an infection, rather the opposite, that you get an even better immunity after that. And possibly vaccination plus immunity from a natural infection would also probably give you a broader immunity and probably better off when it comes to variants in the future. So there's many good reasons to get vaccinated, even if you had an infection.
Thank you very much. And that brings us to the end of today's webinar. I'd like to thank our two speakers for sharing their insights and making the time for that, and also sharing their expertise. Thank you very much, Professor Abdool, Karim, and Dr. Tegnell. I'd also like to thank the Swedish Embassy in Tshwane and the National Research Foundation for hosting this event today. And if you'd like to access a recording of today's webinar, please do keep an eye on the social media platforms of both the Swedish Embassy in South Africa and also the National Research Foundation. There are live stream recordings on their Facebook pages, and they will also tweet the link of the recording on Twitter. Thanks very much for joining us today. Have a good afternoon.
Thank you. Bye.
Thank you. Bye.